Good day, Doctor. Today I'll be introducing Ada Health, which is an AI-powered healthcare tool selected for our project. So as technology continues to develop, more people are turning to online platforms for health information and symptom guidance. In fact, studies have shown that around 80% of the internet users search for health information online, and about 60% look up their symptoms before and also after seeing the doctor. This growing demand has led to the development of tools such as Ada Health. Ada was found in 2011 in Berlin, Germany, and today it has over 13 million users worldwide, with more than 30 million symptom assessments completed. The platform is free and available in multiple languages and is also accessible 24/7. However, it is important to remember that Ada Health is not used to provide medical diagnosis. Instead, it helps users to assess their symptoms and provide healthcare guidance to support decision making. So the question remains, how does Ada actually work? So first, the users enter some basic information such as their age, gender, and also medical history. Then they describe the symptoms through a chatbot. Based on the response given, Ada asks a series of follow-up questions to gather more information regarding the patient's symptoms. This is possible because the system uses Bayesian probabilistic reasoning and adaptive questioning. Once the assessment is completed, the users receive a structured report that outlines possible causes of their symptoms, together with the health information and recommendations on what steps they should take next. While the system can provide useful guidance, it is designed to support healthcare decisions rather than replacing the healthcare professionals.
Our analysis begins with the Ada Health symptom assessment workflow, which we have mapped into 14 stages. The workflow starts when the users open the apps and ends when a triage outcome is delivered. In stage 1, Ada collects demographic information such as age, biological sex, and medical history, which provide the prior probabilities needed for later reasoning. In stage 2, the users enter their main symptom either by typing or by selecting from a guided list. Stage 3 then passes this input and maps it to Ada medical ontology so that the system can work with standardized clinical terms. The workflow then reached its first major decision point at stage 4, the red flag check. If the symptom match emergency indicators such as chest pain or stroke sign, the system skips probabilistic reasoning entirely and moves straight to stage 5A, which advises the user to call emergency service. If no red flag is detected, the workflow continues to stage 5B, where the Bayesian engine generates an initial probability distributions across thousands of conditions. Stage 6, 7, and 8 then form the iterative core of the system. Ada select the follow-up question with the highest information gain. The user provide an answer, and Bayesian inference update the posterior probabilities. This loop continues until stage 9, confirm that the confidence threshold has been reached. Once questioning ends, stage 10 rank the most probable conditions, stage 11 maps them to an urgency level, and stage 12 produce the final triage recommendations. The user then decides at stage 13 whether to seek care, leading to clinician review in stage 14A or to self-monitor through stage 14B. Across this pipeline, the color coding on the diagram represents 3 roles types. Pink boxes are human-driven stages, such as entering demographic data, answering questions, and making the final care decision. Purple boxes are AI-driven stages, including NLP mapping, Bayesian inference, and risk stratifications. Green boxes are human-AI collaborations, where AI triggers an action, but the outcome depends on human response, such as emergency escalations. 4 design principles tie the workflow together: Bayesian probabilistic reasoning, adaptive information gain questioning, and deterministic red flag safety gate, and human oversight at every critical decision point. Although every stage has its own limitation, 3 of them stand out because their failure modes carry serious patient safety consequences. Firstly, stage 4 red flag detections is a single safety gate that bypasses Bayesian reasoning entirely. Its main risk is that a typical heart attack presentation in women, which often appear as fatigue or jaw pain rather than classical chest pain, may not trigger the rule-based detections. Secondly, stage 8, the posterior probability update, is the mathematical core of the system. Its limitation lies in the assumption that symptoms are conditionally independent, which is often violated by syndromes such as sepsis, leading to overconfident posterior probabilities. Thirdly, stage 11, risk stratifications, converts probability into urgency. Its weakness is that the urgency mapping is calibrated for healthy adults, which may cause the system to under-triage elderly or immunocompromised users, who are in fact the most vulnerable groups. To compare prompting paradigm, we test both systems on the same scenario. A 55 years old male experiencing central chest pain radiating to the left arm, shortness of breath, and cold sweating for 20 minutes. With direct prompting, we enter the case into Gemini as a single free text message. The model correctly identified a possible heart attack, but its response was a long narrative in which the urgent instruction to call emergency service was mixed together with secondary advice, such as aspirin dosage. With the structural workflow, Ada Health reached the same emergency escalation after only 7 target inputs. The assessment was held mid-flow as soon as the referred criteria were met. This showed that structural workflow prompting delivers faster, cleaner, and more reliable triage in high-risk situations. From this workflow analysis, three key insights emerge. First, determinism is more important than probability when it comes to safety, because emergencies cannot tolerate uncertainty, which is why ADA plays a rule-based red flag gate before its Bayesian engines. Second, Bayesian reasoning mirrors clinical practice, since adaptive information gain questioning replicates how an experienced physician takes a focused history. Third, human oversight is designed into the system rather than added on as an afterthought, with the user decision at stage 13 and clinician review at stage 14A, preserving final medical responsibility. Together, this design choice position Ada Health not as an autonomous diagnostic authority, but as a decision support tool that guides patients towards the right level of care.
We developed a five-dimensional evaluation framework. The purpose of this framework was to assess both the clinical quality of the system and its practical usability from a patient perspective. The five evaluation criteria are fidelity, coherence, relevance, usability, and consistency. Each criterion was assessed using a 5-point scoring scale, ranging from poor performance to excellent performance. First, fidelity measures the accuracy of the medical interpretation and whether the suggested conditions are clinically appropriate. Second, coherence evaluates the logical flow of questioning and whether the symptom assessment follow a consistent clinical reasoning process. Third, relevance measures how well the question and output align with the symptom reported by the user. Fourth, usability assess the ease of use and clarity of the system, particularly for the user without medical knowledge. And finally, consistency evaluate whether the system produce stable and reliable output when they presented with similar symptom cases. The first test case involved a high-risk emergency scenario. A 55 years old male presented with acute chest pain and several warning signs associated with cardiac condition. The patient described the pain as heavy, tight, and crushing. The pain was located in the center of the chest and radiated to the arm, jaw, and shoulder or back. The pain was severe enough to interfere with normal daily activities and had been present for less than 1 day. Although the patient did not have common risk factors such as smoking, hypertension, or diabetes, the symptom profile still indicate a potentially serious cardiac event. So for the output is, other health correctly recognize the severity of the symptom and immediately display an urgent safety warning. The system advised the user to stop the assessment and seek emergency medical care. However, it also allowed the user to continue the assessment if they wish. So this appropriate balance the patient safety with user autonomy. Here is the evaluation result for case 1. For fidelity, the system receives a score of 5 because it accurately identified a serious cardiac risk. For coherence, it scored 5 due to its logical progression from symptom collection to emergency recommendation. For relevance, it also scored 5 because the question focused specifically on the cardiovascular symptom. For usability, the score was slightly lower at 4 because the user could still continue the assessment despite the emergency warning. For consistency, the system scored 5 since it responded appropriately to a high-risk symptom profile. So in overall, the total score was 24 out of 25. The second test case examined a lower-risk condition. A 24 years old female presented with symptoms commonly associated with a viral upper respiratory tract infection. Her symptoms include a mild sore throat, runny nose, productive cough, blocked nose, sneezing, hoarse voice, and throat redness. She reported no fever and confirmed that she was fully vaccinated against COVID-19. She also had no significant medical risk factor. So for the output, other health identified the common cold as the most likely diagnosis. In addition, the system suggested COVID-19 and influenza as possible risk, but lower risk alternative diagnosis. The platform also provided home care advice for self-management recommendation, and this output was appropriate for a non-emergency respiratory condition. Here is the evaluation result for case 2. The system received a fidelity score of 4.5 because the diagnosis was accurate and supported by the relevant alternative. Coherent received a perfect score of 5 due to the structured symptom assessment process, and the relevance also score 5 because the question closely matched the reported symptom. For usability, score 5 as the recommendation was simple, clear, and easy to understand. Consistency received a score of 4.5 because there were minor differences in probability estimate across similar assessment. So the total score was again 24 out of 25. Despite its strong performance, several limitations were identified. The first weakness is limited transparency in probability reasoning. Although the system provides likelihood estimate for different conditions, it does not explain how these probabilities are calculated. This can make it difficult for users to understand the reasoning behind the recommendation. The second weakness is dependence on user input accuracy. Since the system relies entirely on the information entered by the user, inaccurate or incomplete symptom reporting may reduce the reliability of the assessment. The third weakness is the simplified symptom independence assumption. The system may not fully capture complex relationship between the related symptom, which could affect the diagnosis accuracy in certain cases. Finally, there's an issue of user-controlled escalation in high-risk cases. Even when other health recommend the emergency medical attention, users are still allowed to continue the assessment. As a result, some individuals may choose to ignore urgent recommendation despite potentially serious symptoms.
As for hallucination and reliability testing, the objective here is to stress test Ida Health's Bayesian model to see if irrelevant overlapping syndrome trigger AI hallucination. So, as for the scenario, morning high intensity workout focused on abs and overeating the previous night. The primary input is generalized pain and abdominal pain, which is stomach ache, and both of them we put duration is less than a day. Targeted app prompt selection is yes to body ache, represent workout strain, and yes to fatigue, represent physical exhaustion. So as for the input here, just the representative of primary input, which is generalized muscle pain and abdominal pain. And as for the output, as we can see here, viral stomach bug is the first prediction, followed by acute kidney infection and delay onset muscle soreness of the abdomen, which is what we're looking for actually. So technically, the model make the correct prediction on the third one, while the first two prediction is wrong. It's not like it's not what we're looking for. So let's move on to identification and classification of failure type. What kind of hallucination does AI have? The answer is intrinsic hallucination via single pathway conversion. So the issue is lack of doctor contextual sensibility when dealing with multi-organ symptom. The mechanism is single pathway drift. Initially, stomach input forces the model down a strict gastrointestinal pathway. Follow up input like fatigue and body ache, which is actually caused by exercise, are incorrectly absorbed into that field. And as for the result, the AI ignored the dual context reality, misdiagnosed muscle strain as severe disease or food poisoning. As for unreal, unreliability via forces binary constraint. The issue is human health exists in gray zone, but the UI forces absolute black and white choice. Since ADA use multiple choice response, it's like blocking the patient to give a full input of what they are having. So, for example, a rigid duration option like less than a day versus 1 to 7 days forces users to guess. Sometimes we don't know if it's 1 day or less than a day, which confuses us. So the outcome is the system ingests skewed, inaccurate input data directly, undermining the model's reliability and consistency. Okay. Before I pass the presentation to my friend, I have one last point, which is risk and consequences in real life situation. So first, we have psychological distress and cyberchondria. Misclassification impact will cause confusion between symptom of past exercise soreness and severe pathology. For example, as we can see, the second prediction of the ADI is kidney infection, and it will trigger unnecessary alarm. Algorithmic anxiety. The AI confidence to transform mathematical misclassification into immediate user panic. Of course, if the real problem is from soreness from exercise and suddenly the eye detect kidney infection, of course you will be worried, right? And next, we have inducing cyberchondria, persistent exposure to flawed catastrophic AI diagnosis fosters compulsive health worries and excessive medical vigilance. So, next, we have clinical misdirection and diagnostic delay. So, the anchor effect is a high confidence AI report can subconsciously bias a doctor, trapping them into focusing on the AI suggestion disease. It also wasting resources, which is waste clinical time and medical resources by forcing the doctor to test the wrong organ system. Example, checking stomach instead of the muscles. And then lastly, delay care. The doctor must waste time calming your anxiety and un- untangling the AI mistake before they can actually treat the real simple cause, which is in this case sore muscle. Okay. So now I'll pass the presentation to my friend. Thank you.
For this slide, I will present about the retrieval augmented generation, or we call it RAG. RAG is an approach that combines information retrieval with generative AI. Instead of relying on the knowledge stored within the model, AI retrieves relevant documents before generating a response. The purpose of RAG is to improve the quality of AI generated output. Specifically, it aims to improve factual grounding, reduce hallucination, and increase transparency. For this evaluation, AdaHealth itself could not be used because it does not provide a user-accessible retrieval mechanism. Therefore, we conduct the RAG evaluation using a general purpose large language model within the same healthcare context. The prompt we use is involve a 55-year-old male experiencing severe chest pain lasting for 30 minutes, pain spreading to the left arm, shortness of breath, cold sweating, and nausea. These symptoms are commonly associated with a heart attack and therefore represent a high-risk healthcare scenario. I used ChatGPT to compare the two types of response. The first response was generated without retrieval support, and the second response was generated using retrieval support. In this slide, I will present about the response generated without retrieval support. Based on its internal knowledge, the AI correctly identified that symptom could indicate an acute myocardial infarction or heart attack. It also recommends seeking emergency medical care immediately. Then, the AI advised against driving to the hospital independently, recommends resting while waiting for medical assistance, and highlight the importance of prompt treatment to improve survival outcomes. Although the recommendation provided were clinically appropriate, the response relied entirely on the internal model knowledge. Importantly, it did not provide any reference or supporting evidence to justify its recommendation. As a result, users will have limited ability to verify whether the information presented is aligned with the medical guidelines. This highlights one of the limitations of relying entirely on internal model knowledge. In this slide, I will present about the response generated using retrieval support. Similar to the previous response, AI correctly identified that the patient's symptoms were consistent with a suspect heart attack and recommend immediate medical attention. However, there was one major difference. Direct enable response clearly refers to the authoritative healthcare documents to support its recommendation. For example, information from NHS and Mayo Clinic resources was used to justify why emergency medical care was necessary and what action should be taken while waiting for help. Because the supporting documents were clearly identified, users were able to trace the recommendation back to the original source. This increased transparency and allowed independent verification of the information provided. Therefore, retrieval support strengthened the credibility of the response by grounding in it trust healthcare evidence rather than relying entirely on the model's internal knowledge. In this slide, I will summarize the difference between response generated with and without retrieval support. First, regarding the knowledge source, the response without retrieval support depend entirely on internal model knowledge. In contrast, direct enable response use upload healthcare document as evidence. Second, in terms of factual grounding, the response without retrieval support was generated based on learned patterns from the model training's data. Meanwhile, the right response was supported by retrieved evidence from reputable healthcare organization. Third, for the hallucination risk, because of the hallucination risk, without retrieval support, there is higher possibility of unsupported claims being generated. Retrieval mechanism help reduce this risk by constraining the response using external evidence. Another important aspect is traceability. Without retrieval support, user cannot determine where the information originated. However, with retrieval support, the AI explicitly refers the supporting document used to generate the response. Similar to traceability, transparency to same with traceability, like without retrieval support is limited explanation, and for the with support it have a clear more explanation and improve because users are able to understand how the recommendation were derived. And for reliability, without support is not much reliability because it's only depend on the learning pattern on the internal model knowledge. But with the support, it may more reliable because it refers to the source of healthcare, reputable healthcare, and it can increase the user trust too. Overall, our findings suggest that REC can improve the quality and trustworthiness of AI-generated healthcare recommendation by enhancing factual grounding, reducing hallucination risk, and increasing transparency. For this slide, I will discuss about bias, ethics, and human oversight related to other health. Firstly, other health may be affected by several forms of bias that could influence the recommendation it provides. The first bias is user input bias. Other health depends heavily on user accurately reporting their symptom, medical history, and other relevant information. However, not all users have the same level of health literacy. Some users may misunderstand the medical terminology or forget to mention important system. As a result, the system may generate recommendations that are less appropriate for the user's actual condition. The second type of bias is knowledge-based bias. Other health relies on underlying medical knowledge based to generate its recommendation. If the medical knowledge used during development does not sufficient to represent different population, healthcare setting or demographic groups, the recommendation may not be equally accurate for everyone. This may affect the fairness and relevance of the outputs generated by the system. And the third bias is automation bias. This occurs when users place too much trust in AI recommendation. Some individuals may assume that the advice provided by other health is always correct and delay seeking professional medical consultation. This over reliance may get raised, especially in high-stake healthcare situation. Next, I will discuss about the ethical consideration. First ethical consideration is privacy and confidentiality. Privacy and confidentiality are important because other health collects sensitive health information during symptom assessment. Therefore, strong data protection measure and responsible data governance practice are necessary to safeguard patient information. Second, transparency is important. Users should understand that other health provide health guidance and trust support rather than definitive medical diagnosis. The capabilities and limitations of the system should be communicated clearly so that users do not develop unrealistic expectations regarding its performance. And the third ethical consideration is accountability. Accountability should remain with a human stakeholder. Responsibility for healthcare decisions should not be transferred entirely to the AI system. Instead, healthcare professional developers and users all play important roles in ensuring the safe and appropriate use of healthcare AI technologies. And lastly, human oversight. Human oversight remains crucial. Other health should be viewed as a decision support tool rather than a replacement for healthcare professional. Clinician can interpret AI recommendation alongside patient history, physical examination, and contextual information that may not be captured by the AI system. Human oversight help minimize risk associated with inaccurate output and ultimately ensure patient safety.
After analyzing Ada Health, we found that it presents both opportunity and also challenges. One of its main advantages is that it improves access to health information and also may help users to recognize potential health concerns much more earlier. It can also support users in making much more informed healthcare decisions. However, the quality of the results depends heavily on the information provided by the user itself. If the symptoms are described incorrectly or incompletely, the output may not be so reliable. Now, because of this, AI systems like ADA should be viewed as a support tool. Their output should be treated as additional information rather than the final answer, with human oversight continuing to play an important role. To conclude, ADA Health is an effective healthcare support tool that helps improve access to health information. Our analysis has identified several strengths, including its structured symptom assessment and its ability to support patient engagement. However, we have also identified several limitations, such as dependence on the user input quality and the risk of users misinterpreting the information provided. Overall, ADA should be used as a support tool rather than replacing any healthcare professionals. As AI continues to evolve, responsible implementations, transparency, and also ongoing evaluation will remain important to ensure that these technologies are used safely and effectively in healthcare. That's all from us. Thank you.